did so, as opposed to only 6% of those on placebo. This has been confirmed looking at romuplastid, and again this looks at the HCV RNA of these patients compared with the platelet count. You can see the platelets were very low when romuplastid was started. It came out with dose adjustments, but the anti-HCV was able to be continued over that 12-week period in the middle that allowed a clearance of the HCV RNA, which has remained cleared for a good 40 weeks, nearly a year post-treatment. So, in summary for these patients, practical strategies to manage thrombocytopenia in HCV, transfusions from basic procedures are reasonable at platelet counts of less than 50, greater than 50. They're unlikely to bleed there. Transfusions are not indicated prior to anti-HCV therapy because platelet transfusions last less than a few hours and they're ineffective for long-term reduction in bleeding episodes. And so we feel these newer treatments, the thrombopoietin, and certainly the main published study has been with L-thrombopoietin, have shown they raise platelets. And it's a very effective treatment, both to give definitive HCV therapy, anti-HCV therapy. It's also a very useful treatment to have as an intervention if you're actually going into liver biopsy or you want to sclerose varices or you need to do some sort of procedure. So it's very effective from that point of view. So my final slide, thrombopoietin is a fascinating agent. We use the thrombopoietins in a number of ways. There's rarely an absolute deficiency in thrombopoietin, but that's what we see in liver disease, and that we're giving replacement therapy. More commonly, as I've shown with ITP, there's a relative deficiency, and that's what we see in ITP, that's what you see in straightforward HCV thrombocytopenia without liver disease. That's what we see in the congenital thrombocytopenias, that's the MYH9 thrombocytopenias, and that's what we see in the reduced stem cell numbers in patients with aplasia, in MDS, and post-chemotherapy. There's a suggestion that, as with EPO, thrombopoietin levels may be able to predict when you're going to see a platelet response, but that needs a lot more data. Thank you very much for your attention.
Professor Newland, thank you very much for coming here to Egypt and for giving us your amazing talk. Professor Newland actually is a professor of hematology at Barts in London NH Trust, and it's quite an honor to have you here. So the floor is open for questions. Yes, please. Do we have a mic here? A mic, please.
There's one just coming.
Thank you, Professor Adrian, for this highly comprehensive talk. Please, sometimes you may have with high-degree refractory to whatever lines of medical treatment and is unfit for surgery for splenectomy. Please, what about the role of splenic embolization compared to splenectomy and surgery?
I think splenic embolization is a treatment that we've used in the past. I have to say that over the last decade, we've not used anything like that. Splenic irradiation as an alternate therapy as well in those circumstances. But we found, certainly initially with anti-D in the late 90s, more recently with rituximab, but more frequently recently with the thrombopoietins, all these agents are splenectomy saving. And what we've seen, certainly in the UK and in Northern Europe, is a significant reduction in anything that touches the spleen, purely because once the spleen stops working, the patients are very prone to infection. So there's been quite a drive to look at spleen-saving treatments, which is, I think, one of the reasons why we've looked at some of these treatments in much more detail. But the answer to your question is if you have experience with splenic embolization or splenic irradiation, both are potentially effective, at least in transiently improving the platelet count of the refractory patient.
Actually, I have 4 cases after splenic embolization was successful increasing of platelet count.
Yes.
Thank you.
Thank you.
May I have a question, Professor Newland? Yes, okay. Regarding PKO receptor agonist, okay, now as thrombopoietin or Trombag, You said in your presentation it's for 6 to 12 months in regarding second-line treatment. Do we have to stop it at once, or can we do a tapering for the dose?
We tend to taper the dose purely because if you stop it at once, probably 10% of patients, the count will fall very dramatically. And bleeding is usually provoked by the rate of the fall of the count rather than level it goes to. So we will tend to taper it off over a period of 1, 2, 3 weeks, in the hope that if the platelet count is going to come down, it will come down slowly rather than drop. So yes, we would certainly always taper the dose.
Don't we have a maintenance dose? Do we need a maintenance dose or not?
Well, we look for a maintenance dose. I think that if we can taper the dose, the drug down, and the count stays up, then we will continue to taper. If we taper it, the count starts to fall, then we may just continue at a lower dose and continue that indefinitely and see what happens. But yes, we try and reduce the dose as much as possible, just purely because of cost.
So you think it's TPO, it's the future for thrombocytopenia, whatever it's severe treatment, thrombocytopenia or antibiotic or immune?
I think that for the foreseeable future, the thrombopoietins will become the second-line treatment of choice, and hopefully the costs will fall. I think the dramatic reduction in splenectomy we've seen in Europe and in the UK and in North America reflects the fact that physicians treating ITP now have an agent that works in 70-80% of patients and prefer to do that. And actually, a lot of the drive, certainly in England, has come from patients themselves who are aware from the internet of the options and have opted away from surgery.
So, in the future, no role for splenectomy? I think so.
I think splenectomy has dropped off dramatically.
Okay, thank you. Any other questions? Yes. So.
Thank you. What the relation between patient with virus C or hepatocellular carcinoma and the platelet count?
Sorry, between
patient with virus C and hepatocellular carcinoma with platelet count relation.
Do you mean level, Dr. Professor? Do you mean level of platelet count or
platelet count
in treatment of hepatocellular carcinoma? Okay. Professor, in the United States, you mean that the lowest level you can treat patient with vascular carcinoma secondary to HCV, Hep C?
Well, I think that it's very difficult to be dogmatic with that because depending on the level of underlying liver disease, patients may bleed at higher levels. So we use that very much on the level on what problems the patient has, unless we're trying to give anti-HCV treatment, in which case if the count is less than 50, we know it's going to fall, and we will give thrombopoietin treatment to cover the period of treatment. So I think we can't be clinically certain because of the very mixed patterns of what's going on in the patient with HCV, with an element of liver disease, with bone marrow dysfunction, and with underlying clotting abnormalities.
Any more questions? If not, Professor Newland, it's a pleasure and an honor to have you here. And we have just a small thing for you because you weren't here yesterday at the dinner, so we'd like to give it to you now.
Thank you very much.
Now we're going to close the session. We have 45 minutes for lunch, and then we will start with the plenary session and an amazing hematology program that will start after lunch.